It's great to join everyone virtually. As Krishna mentioned, what I'll talk to you briefly about is our experience with a 0.55 ramp down system, which is similar to the system at USC, as well as the work that Adrian showed. And these are my disclosures. And what I'd like to do over the next 20 minutes or so is to talk about why are we interested in doing lower field imaging, in specifically in abdominopelvic imaging. What are some of the challenges, which are some of them are very similar to what we heard about already from Adrian. What are some of those challenges, and how do we actually think about overcoming those challenges? And why, in some ways, time is good right now to take advantage of some of these enabling technologies and methods to overcome the challenges with low field imaging. So I'm going to start by this slide here. This was a talk at NYU by one of the professors of population health. And the idea here was that current delivery of healthcare is episodic care, such that patients get sick and then they go to the doctors or hospitals. And that's where the imaging plays a role. We are part of that episodic care in patients. However, if you think about how the population health is moving towards continuous care, where patients' health will be assessed continuously, and only when there's a disruption in patient's health, then you would guide patient to get a care, which will become episodic. So there's a continuous care model, and then episodic care is spaced out along that timeline. And the question is imaging and MRI then destined to be a backup player as its role in episodic care, or do we actually have a role in providing and be part of this continuous or preventative health that we think about? And so one area where we routinely use imaging and MRI is as a problem-solving tool in abdominopelvic imaging, right? It's not a first-line modality for many applications, and we use it when CT or ultrasound is not able to provide an answer, and then we use imaging with MRI to solve a problem. And let me give an example, a concrete example of that. So hepatocellular carcinoma or liver cancer is the second leading cause of cancer-related mortality worldwide, but the clinical guidelines recommend screening for these cancers or these patients with ultrasound every 6 months and plus minus a blood test for alpha-fetoprotein. Studies have shown that ultrasound has a low sensitivity for detecting small early HCC, as low as 47% in a meta-analysis that was published recently. We know that MRI actually is superior to ultrasound with higher sensitivity and specificity for detecting liver cancer. There has been head-to-head comparison where studies have shown that MRI sensitivity in this study was about 83% compared to that of ultrasound that was about 25%. So despite this added value of MRI in detecting HCC, we continue to survey these patients with ultrasound. And the reason is because of cost and accessibility. MRI is a much more expensive test and much less available. There are also issues with longer acquisition time, and that also increase cost and discomfort. And then yes, MRI is not always very robust, especially when compared to CT, given that it's impacted by motion and the long duration of the exam. And the question is, can we do better, right? And so there are a couple of ways that people try to address this problem. One is to decrease the number of sequences. So we look at our protocol and say some of these sequences are maybe not as information, have a lower information content and don't provide the same degree of information, then maybe we can eliminate those. And that's the idea behind abbreviated protocols. Can we make sequences faster so that we use those sequences, but now actually make them acquire the information content in a less amount of time? And if you do that, then you have an accelerated exam that can be combined with abbreviated protocol. Even when we do this, we really don't truly solve the problem of cost and accessibility, just because the MR scanners themselves are really expensive, right? And so one of the ways to think about changing this dynamic of accessibility is to think about the hardware. One is to think about lowering the cost of the scanner. And I think Adrian showed a really great figure that the magnet and the gradient systems are drivers of these costs. Another cost, especially where I come from in New York, is actually the construction and shielding costs associated with the scanner is probably as much as the cost of scanner itself. And so if we actually think about having a really getting to a level where you don't need shielding, then you would have significant impact on both the cost and housing of these magnets that would be make it more accessible. Power requirement is an issue, and then just the complexity of doing an exam is a problem. So if you can address these aspects of scanning, then maybe we can address the accessibility barrier. And so that's where one of the things come in with lower field, lower cost scanners, right? And that's where we were excited to address this issue. So advantage of low field, as I think we already learned about from earlier talk, is that hopefully it's lower cost, it improves accessibility, maybe improves patient comfort as well, and then reduces susceptibility and other artifacts. The challenges, of course, is that lower the field, reduce the SNR and corresponding long acquisition time. And so as we talked about earlier, our experience was that we took a really good 1.5 Tesla scanner and we purposely ramped it to a 0.55 Tesla. So this is a precursor to the free Max system. And obviously the challenge is that the MRI signal has a quadratic dependence on the static magnetic field. So SNR is proportional to the static magnetic field to the power of 3/2. And if you think about going from a 1.5 Tesla to a 0.55 Tesla system, you would have a decrease in SNR around 1/5 or 1/6 the SNR that you would expect based on this theoretical calculation. Although studies have shown that the SNR loss is a little bit less than the theoretical calculations. So this was a really nice GMRI review paper. And basically what they suggested in that paper is that the SNR loss in brain was smaller than predicted. So it wasn't as much as 1/5 or 1/6 SNR, but it was less than that. And so let me show you the example of what I mean by this SNR loss. So this is a T2 turbospin echo or TSE imaging of the prostate. And basically this was performed on a 0.55 Tesla, where we wanted to get image quality similar to 1.5 Tesla acquisition. Our 1.5 Tesla acquisition, we performed with 3 averages or 3 necks. Here, instead, we are acquiring over 10 averages to get sufficient enough SNR as we would expect on a 1.5. So this is a 4-fold increase in acquisition time of nearly 18 to 19 minutes. And this in itself is really problematic because this is not feasible to have these kind of long acquisition time and perform diagnostic imaging. So we need to address some of these problems with low SNR. There are a couple of ways we can think about addressing these issues. We can manipulate sequence parameters. Again, as Adrian talked really very well about the fact that we are in a low SAR regime, so maybe we can modify some of our sequences to get more information content per unit time. We can take advantage of the longer T2 star at lower field. And then maybe we can compromise on some of the resolution and acquisition time such that we can find a sweet spot where we can still perform diagnostic imaging with a longer acquisition time. So let's start, again, I'm going to talk mostly about abdominopelvic imaging, but I wanted to show this example in lumbar spine. This is a work done by Jan Fritz and some of my colleagues at NYU. And basically what we see here is on a top row is a 1.5 Tesla acquisition with corresponding acquisition time. So we're performing a T1 weighted imaging, we have inversion recovery, T2 imaging, and in both sagittal and axial plane. And the bottom is an optimized protocol of 0.55 Tesla to maintain the same degree of SNR. And what we can see here is that if we try to match the SNR to a 1.5 Tesla acquisition, you end up having acquisition time that's about 4 to 5 times longer. But you can get exquisite, similarly diagnostic information as you would have gotten at a 1.5 Tesla system. And this is one of the advantages of having a high performance system where we're actually able to get images that are diagnostic, but at an expense of longer acquisition time. When we talked about applying this to abdomen, our feeling was that we did not want to have acquisition times that are 4 or 5 times longer. We wanted to be about in a two-fold longer acquisition time. And that required maybe some compromises, some manipulation of the sequences, but some also compromises in things like resolution and slice thickness. We're showing images here of a T2-weighted imaging performed on a 1.5 Tesla system and at a lower field system with two different gradient configuration, the high performance gradients and the lower performance gradients. And we did that for T2-weighted imaging, T1 Dixon imaging. So you have a T1 fat set or water images and our diffusion-weighted imaging. And basically, what we did was that, as you can see here, we tried to have our acquisition time in about twofold longer than our 1.5 Tesla acquisition time. And then we had readers evaluate image quality on the Likert scale from 1 to 5, where 1 being non-diagnostic and 5 being excellent for each of these contrast mechanisms. And what we see here is that for T2 fat set imaging, as you see here on a 0.55 Tesla system, the image qualities were ranked to be diagnostic, although of lower image quality compared to 1.5 Tesla acquisition. And that applied both for T1 Dixon imaging as well as diffusion-weighted imaging. So our conclusion from this was that you can generate diagnostic images, good images that are considered diagnostic by radiologists for evaluation of liver parenchyma and upper abdomen, however, at a cost of a longer acquisition time. And images, although were good, they were not at the same level or same image quality scores as a 1.5 Tesla acquisition. So the question is, can we do better? And what are the tools we have that we can deploy to improve our image quality and decrease acquisition time? And I'm going to talk briefly about a few of these methods that we are exploring right now. One is the idea of multi-contrast imaging, so you can acquire more information content per unit time and acquire it more efficiently. And then we'll talk about a few methods of accelerating our acquisition and reconstructing from undersampled data using compressed sensing and machine learning methods. And then I'll briefly talk about one of the techniques that we've been using to denoise our images, again, allowing us to accelerate our diffusion-weighted imaging with a technique called random matrix theory-based reconstruction. So this is some of the work that we had done earlier on a 1.5 and 3 Tesla system that now we're deploying it on a lower field system. Here we are basically performing a single free-breathing radial acquisition. Again, it's a free-breathing radial acquisition, so we don't have to give breath-hold instructions. It saves time. And then we are acquiring both T2 and T1 weighted contrast in a same single radial acquisition. And the idea here is that during the recovery for T2 signal, we are basically have a T1 module that we incorporate into a single acquisition. And we're able to get a T2 weighted imaging and our Dixon T1 weighted imaging that provides in-phase images, post-phase images, and water-only or T1 fat set images. And this basically constitutes our non-contrast imaging of the abdomen. We've tried to extend that even further by doing a multi-echo T1 weighted imaging, where we're now getting not only T2 weighted imaging as well as T1 weighted imaging, but also doing multi-echo T1 weighted imaging to get our fat fraction or PDFF as well in the same time. Again, the idea is that a single 8 or 9 minute radial acquisition that allows us to encode for multiple contrasts can help us be more efficient and can get a non-contrast liver imaging in maybe 8 or 10 minutes. Again, we're really interested in kind of combining these kind of acquisitions with methods to accelerate further, and that would require undersampling and reconstructing from undersampled case-based data. And the techniques we've been exploiting is compressed sensing and machine learning-based methods. So as you all know, MR images are compressible in some domain for many different types of contrast, and we can exploit this compressibility by undersampling acquisition and reconstructing with compressed sense types of reconstruction. Again, so the requirements for compressed sensing reconstruction is the fact that MR images have to be sparse or compressible. We acquire the data in a random acquisition schemes. We acquire quite many of our acquisitions with radial acquisition schemes, can acquire with a non-Cartesian spiral acquisition schemes, and then you can basically use a nonlinear reconstruction to suppress undersampling artifact while maintaining the information content. And we've done this for a few different types of contrast. This is a MRCP acquisition. Again, MRCP is a heavily T2 weighted acquisition looking at pancreatic and biliary ducts, as well as pancreatic pathology. information content is in small number of voxels, and so we can really undersample our acquisition. We're only acquiring 5% of the case-based data and using compressed based methods for reconstructing that. This is the images that we've been doing at 1.5 and 3 Tesla, and we're starting to apply that on a lower field system, as we see here. Another methods that that we are truly exploring is machine learning based methods for image reconstruction. This is the area that has seen incredible progress in the last couple of years. I love showing this because a lot of work has been done in the last 5 years that have revolutionized, or at least starting to impact even clinical care by using some of the convolutional network-based methods for image reconstruction. Just very briefly, just to review, there are a couple of ways we can think about applying these methods for image reconstruction. We can acquire undersampled case-based data and train a network to fill in the missing case-based data, perform inverse Fourier transform to generate diagnostic image. Here we're training our network and deploying our network in the case space. Other ways to actually undersample case-based data, generate an image with Fourier transform that would have undersampling artifact and aliasing artifact, and they can apply a neural net to clean up those artifacts and generate clean diagnostic images. Here we are deploying our training and network in image space. We can think of directly going from undersampled case space to diagnostic image. This is the way, many techniques like AutoMap do this. This is computationally demanding and a little bit difficult problem to solve. And the technique that we have the most experience with, and I'll show you a little bit about, is the idea of unrolled optimization, where we're just learning the steps of compressed sensing and are using machine learning based methods to do that reconstruction. Here, our input is undersampled case-based data and quality sensitivity map. We reconstruct those images while performing data consistency along the way. And we'll show you a little bit of that here. So that example I showed you of prostate images where we're acquiring 8 or 10 averages to reconstruct images that result in a 15 to 20 minute acquisition time to get a target image. So here, instead of actually using all 8 averages, we can train a network where we feed in our input is undersampled images in undersampled case space from 2 averages. So this is a 4-fold acceleration. And the output of the network is then compared with our target image. And we penalize, that's a loss function, we penalize the difference. And basically, this kind of a network, the output is to generate images that are similar or as close possible identical to a target 8 average images. And so we are getting a 4-fold acceleration. If you think about that, then now your acquisition time is about 4 to 5 minutes rather than 18 to 20 minutes. And that is similar to what we would get on a 1.5 or 3 Tesla system. So to show you an example, initially we trained our network on a 3 Tesla data because we just had a lot more data to train our network. This is a conventional T2 TSC of the prostate. That's acquisition time is about 3 minutes and 45 seconds. It's a 6-fold accelerated reconstruction. And basically her acquisition time is about 40 seconds, which is a similar image quality as conventional acquisition. And now we're basically hypertuning this network from data from a low field system. And again, just showing you that this is a 6-fold acceleration, trying to get images which are similar to that we would have gotten with 10 or 10, 8 or 10 averages, but now using only 2 averages. And so again, this is a work in progress. I think we can still do further much better, but basically that is what we are trying to do, using this the VN networks to achieve 4 to 6-fold acceleration on a lower field. Another way that we've been deploying for improving and accelerating our diffusion imaging is this random matrix theory based reconstruction. Here we are removing noise by leveraging the low rank nature of the diffusion exams. Diffusion imaging is performed with multiple B values, multiple directions in the multiple images. So the underlying noise has the same structure for these acquisitions, and then we can exploit that to identify the noise only eigenvalues and remove them using MP distribution. And just show you some example of that here. So this very last column is a acquisition performed on a low field system with 8 averages for low B value and 40 averages for high B value of B1000. And this exam would take anywhere from 15 to 18 minutes. Now, basically, if you look at the very the left column here, we are basically undersampling with 3 averages of B50 and 3 averages of B1000. B50 is not too shabby, but if you look at B1000, as you can see here, this has a really very low SNR and non-diagnostic. But using an RMT-based denoising methods, we can remove that noise, and now we get a B1000 images that are of diagnostic quality. And if you undersample, significantly from a standard reconstruction, just getting 3 averages at B50 and B1000, we are able to get significant acceleration in 6 to 10-fold acceleration. And these kind of images now can allow us to perform diffusion imaging in prostate or in abdominopelvic applications with acquisition time that can range around 2 to 3 minutes, which are acceptable for clinical practice. So I think what I've tried to do over the last 20 minutes or so is to briefly talk about role of novel methods that can allow us to perform imaging at low field with the acquisition time that is acceptable for clinical application. We can think about maybe manipulating sequences and manipulating some of the acquisition methods, maybe compromising some resolution to achieve some degree of acceleration. But these novel methods that we just talked about can further enable us to achieve acquisition times and image quality that are comparable to 1.5 Tesla system. There's a lot of interest in exploring these methods, and if we're able to demonstrate the value of these methods to be that diagnostic, then maybe we can target the accessibility and cost problem with MRI, and maybe then we can make it more accessible and less expensive and apply it for many, many oncologic abdominopelvic applications. So really, thank you very much for your time, and I'm happy to take any questions.